The first one is to provide some education on the relevant aspects of the health system and health policy and the trends that you as leaders should be paying attention to. We hope that you come away with a better understanding of what this means for your organizations and sectors. We want to give you some practical ideas to help you interpret the changes that are underway and will continue to better steer your organizations. And lastly, we want to highlight the ways in which your sector can take leadership during a time of uncertain change. So no doubt you're thinking a lot about the role of government in healthcare these days as we head into a provincial election and then soon after that municipal elections across the province. So the presentation discussion is very mindful of the unique context that we're in, but at the same time we designed it so that the webinars will continue to be relevant over time regardless if there is a shift in government or policy directions, because as you well know, change in healthcare never stops. So before I pass it over to Adriana to open the discussion up, I want to briefly go over the agenda and logistics for today. So we designed the agenda so there's a mix of presentation and discussion. We want you to have some time to answer questions and really dialogue amongst yourselves. The entire session is 90 minutes. So following the intro and the CEO remarks, we really have 3 sections, and each section will be followed by 10 minutes of Q&A and discussion. The first section is called the Canadian Health System, a Macro View. The second focuses in on the Ontario system, and the third looks at how this impacts your unique operating reality as community health centers and family health teams. We want to emphasize again that the webinar, this first webinar, is really meant to be a broad brush overview of the main features of the healthcare system and health policy. There will be an opportunity for you to address some of your more specific questions in the Q&A, and we do hope that you join us on April 26th for the second webinar where we're going to do a deeper dive on Ontario's policy and environment, the political dynamics, and some of the healthcare reforms such as integration that you're all very interested in. We'll get into that in greater depth. So just a few logistical things about today. If you have any technical or audio questions or issues, please call Citrix at this number, 1-888-259-8414. That's 1-888-259-8414, and use the webinar ID that you've been given. This number, Citrix number, was with your agenda, so you have it on hand, but in the event that you forgot the number, you don't have it handy, you can always just send us a chat and we'll send you the information right away. We will be using the chat feature for asking questions and making comments. The chat option is located in the bottom of your control panel. Some of you will have experience using this, some of you won't, but it's very straightforward. Click on the plus sign that's next to the word chat. It'll expand the chat box and then you can type in your message. You can ask questions and make comments anytime throughout the presentation, but we'll be addressing them right after each of the sections. We have some of our SANTS team members will go through and group the questions as they come in, and we're going to try and respond to as many as we can. We know that we won't be able to get to all of them, but rest assured the whole session is being recorded and we will capture all of the questions, and the associations will be able to put out a more comprehensive Q&A after. The last thing I want to point out is in the last section, your operating reality, we did pre-circulate a question for the AOHC and AFDO members, and we're hoping that you can reflect on the questions and share your experiences using chat. You can type up your kind of experiences and observations around the question that we asked anytime, but we do want to spend time at the end in that last section. I'm hearing from you your kind of ideas on that question. And as I said, the webinar will be available on the association's various websites following the session, so anyone who missed it can check it out then. And is now my pleasure to ask Adriana to provide some opening remarks.
Thank you, and I really welcome each of the participants who are on this webinar. You are the current and emerging leaders in primary healthcare. I think on the phone or on the webinar, we have members from community health centers, Aboriginal health access centers, nurse practitioner-led clinics, and family health teams. And you really do represent the interprofessional primary healthcare future in this province. So really appreciate that you took the time to be part of this really important webinar. And And I believe that you did take this time because you're really interested in learning about how the healthcare system works in Ontario, and figure out how better to position yourself as individuals in the job that you do, your center and your organization, your team, and yourself in this changing landscape. So on behalf of Kavita Mehta, CEO of AFTO, and myself, Adriana Tetley, we welcome you to this really important webinar. As was stated, we are in a very changing and very disruptive landscape. And if you are a political junkie, I'm not sure how many times people have asked me what I think is going to happen. For those of you who know me and have heard, I do a session called Tetley Reads the Tea Leaves. So they are asking me, what do I think the election outcome is going to be? And I'm telling you, I don't think I have any foresight into that at all. And it's very hard for us to see past the next few months. But I don't often see disruption as a barrier. I often see it as an opportunity. And this period of disruption is often where we can influence the agenda. And that's the way that we need to look at this as we go forward, because it won't just be the election. It'll be the weeks and the months after the election with whichever government gets elected that we need to be able to position ourselves and figure out how to move forward. In order to do that, though, we need to understand the system that we're in. And that's why this webinar is so important, because unless you understand it, you don't know what the levers are for you and where you need to be to position yourself to actually make change to influence that system. So this is the first of two, and we really do encourage you to join the next one as well, which will go even deeper. There are many shifts. You're going to hear about this in the webinar, but there are many shifts happening in healthcare system. One of the first ones that you've heard a lot about is the transition of care from hospitals to the community and the expectation for community partners to step up. And I know many of you are experiencing this in different ways, because in some cases, the hospitals are transitioning that care and just stopping the services and it's landing on your doorstep with no planning. In other times, you're actually in partnership with the hospitals and there's a warm handoff and you're being asked to step up and take the care. But these things that you're going to be asked to take on are going to increase over the next period of time, not decrease. In the past as well, hospitals were seen as the anchor of the system. And we really are trying to shift that perception, because the anchor really is the community sector. We are supportive of the hospitals. We want them there when we're sick. We want them when we're in an emergency. We really do need them to be there to do their role. But we do way more than that. We really want to treat them when they're sick and we can manage them in the community. We also want to have their help in managing our chronic conditions, but they're also increasingly wanting us to keep us well in the first place, keep the people you serve well in the first place through prevention, through the focus of determinants of health. For primary care specifically, we believe that everyone in Ontario should have access to person-centered services and programs from a strong foundation of primary care in their community, which actually engages people to achieve their optimal health and well-being throughout their lives. We also believe, and primary care is increasingly being asked to coordinate and navigate the services that the people need, so that there's smooth and effective and seamless transitions from your office, from your center primary care, to the other parts of the healthcare system and social services system, and then back to you in a smooth transition way. We also are in a world where planning is no longer about the people who come through your door, but planning about what the needs are of your community that is population-based and actually meets those unique requirements of your community and the populations that you serve. In addition, increasingly, you're being asked, it's no longer good enough to just do your family health team. You're being asked to partner with mental health and addictions, with other community partners, with hospitals, with LHINs, to be at tables and to figure out what an integrated health delivery system might look like, often at the sub-region level. A really big shift for some of you on the phone, and I know with the family health teams particularly, it's a newer thing. In the past, you were thinking about the clients you were rostered, and those were the ones you were taking care of. But increasingly, you're going to be asked to serve the people who aren't coming through your door, and how do we take care of the people who are not getting the services that they need, so that you can be part of that solution at the whole system. So in order to navigate this complex system, and in order to step up and be leaders, as I know the healthcare system is looking for us to be, we need to build leadership, capacity, and your confidence. We need to be at tables to participate and shape this change. And in primary healthcare leadership, you have to be active at your center, at your local level, in your communities, increasingly at your sub-region level, and LHIN-wide. And we really encourage you during this time to not wait for leadership from the ministry or the LHINs. We really believe that this leadership, this shaping of this change, has to come from the community and grow up. For the family health teams, you're new to the LHIN world. And one of the messages Kavita asked me to say to you is that you don't need a formal accountability agreement with the LHIN to start participating with the LHIN. Don't wait for that. Start now to begin to engage with your LHIN. Help them to co-design, co-inform, and be part of solution making. So in closing, you are the current and the future leaders for primary health care that can lead us through system transformation in partnership with our mental health and addictions partners, our community partners, and other parts of the health system, including the hospitals. Thank you for your interest, and I will now turn it back over to the facilitators for this webinar.
Thanks very much for that, Adriana. That was great, I think, to put in context for the people that are joining in today, not just the purpose of this webinar, but the efforts of your association and the other associations to really provide new and emerging leaders and established leaders within the sector a little bit more of a window into the dynamics that are shaping decisions across the system. Where we're going to start in this section is to really provide a 50,000-foot overview of how our Canadian healthcare system operates. And this will touch on the complex history over the past 150 years, but really try and focus on how this is relevant to the work that you do on a daily basis. And you might be questioning, why are we looking at the history of the Canadian healthcare system? Well, the argument that we're going to make here is that the dynamics that you face, the challenges that you face, the challenges that your association and your sector deal with every day, and issues like for the home or for the primary care sector, the fact that only about 30% of the population in Ontario has access to broad interprofessional team-based care, yet everyone has access notionally to physician, medically necessary physician services. Why is that the case, and how does and what can we do about that? How does the history of the political decisions that were made largely at the provincial and federal level over the past 150 years contribute to the system that you're operating in today? Our belief is that by understanding how all of these pieces fit together at the macro level and understanding how our system has evolved, you as leaders are better positioned to drive forward the changes from the ground up to address the current challenges that our healthcare system faces. So now I'm going to look at the kind of key features of the Canadian healthcare system. And what we tried to do is, if you were to take a step back and look at the Canadian system from the perspective of an outsider, from the perspective of someone who might be visiting here from Europe or from Australia or from the US, what makes the Canadian system different than our peers? And every health system across not just the OECD, but the world is more broadly, has made different decisions about how to organize, manage, structure, and ensure care that are informed by the unique values and the culture and the history of that country. And these are 5 of the key kind of features that are unique in the Canadian system. The first is that Canada, of course, has a federal system of government. And what that means in healthcare is that there are different responsibilities for the provincial and federal governments. While provinces have clear responsibility for organizing, funding, and overseeing the delivery of health services, the federal government has a huge fiscal role in collecting and distributing tax revenues. And it's largely through this fiscal responsibility that our federal government plays a significant role in Canadian healthcare by providing money to provinces essentially in exchange for their agreement about the provision of a minimum standard of care across the country. This federal-provincial dynamic has continued to evolve over the past 150 years of Canada's existence, and the Health Accord negotiations from last year are just the most recent example of the evolving provincial-federal dynamic. Second feature that I want to highlight that's very obvious and evident to the folks in this webinar is that Canada, uniquely in the OECD, has a universal single-tier system, but just for physician and hospital services. 100% of medically necessary physician and hospital services are provided free at the point of care with no copay, and really no ability for people to access a second tier of private pay for medically necessary physician or hospital services. But the flip side of this universal single tier coverage for those services is a real patchwork and an uneven degree of coverage for non-physician, non-hospital services in Canada, and a very, very high degree of private pay for a range of services compared to our OECD peers. And that's not just for the non-physician services in primary care. It's for things that, you know, your patients might rely on, like dental care, drugs, community mental health services, a whole range of services in Canada where there's a greater reliance on private pay than in other OECD countries. The fourth factor, which is really tied into this earlier point that Canada is a federal system, is that provinces and territories have so much latitude to design, organize, and fund their healthcare systems, especially outside of physician and hospital services, that you really have 13 different distinct provincial and territorial healthcare systems, not one unified Canadian healthcare system. And you can see that in looking at primary care models across the country, where there's quite a significant degree of diversity in provinces about how primary care is structured, organized, and paid for. On the next slide, what we're trying to do here is distill down 150 years of complex history into a few bullet points in less than 5 minutes, and talk really about the key things in our country's history that impact the work that you do today in the Canadian healthcare system. And the first thing to really note is the passage of the British North America Act in 1867, which created Canada as an independent country and became the constitution for the new country. As many of you know, the BNA gave the provinces exclusive authority over what was at the time in the Act referred to as hospitals and asylums, and and a few other things. The courts subsequently interpreted that language because it was really silent on other healthcare services to mean that the constitutional responsibility for the oversight and delivery of healthcare services rests exclusively with the provinces. But although the federal government has no formal constitutional role, with the exception of its role for armed services, First Nations and Inuit, for healthcare provision within the constitutional framework, the broad fiscal powers that the federal government has really give it a backdoor into the healthcare conversation. They can buy their way in by providing healthcare transfers to the provinces in exchange for accountability about how that funding will be used. That really started, that federal role in providing funding to the provinces for healthcare started as early as 1940, when the federal government transferred some money to the provinces to be able to pay for new hospital construction and new beds. I mean, at that time, of course, there was no real broad-based public coverage for essential health services. That changed only when Saskatchewan led the charge to ensure public access for hospital services under Tommy Douglas's leadership, with other provinces eventually following suit, which prompted the federal government to step in 1957 and basically offer a deal to provinces whereby the feds would provide funding to help support public coverage for hospital services across the country. That infusion of federal money in Saskatchewan, where they'd already taken the step to pay for hospital services, led the NDP government there to really take the next step and use that money to fund medically necessary physician services. And Saskatchewan in '62 created the first medical insurance plan for physicians. And although that was an incredibly contentious move with the physician community, and was ultimately a factor in the government being voted out in the next election, the policy was incredibly popular and succeeded in sparking change across the country, with other provinces also moving to provide public coverage for physician services, which was then fully enshrined in 1966 as the new national standard, when the feds agreed to provide matching funding to all provinces who would offer universal hospital and physician services. And that really was kind of the deal until 1977, was that there was 50-50 cost sharing between the federal government and the provincial government, an equal shared endeavor in healthcare, with each playing an equal role in funding. But because of the constraints of the funding agreement, that it focused exclusively on medically necessary hospital and physician services, that funding arrangement really didn't keep up with the realities of the changes in the needs of patients and the way healthcare systems were operating at the provincial level, with an ever greater focus on, as Adriana suggested, as community services being recognized as a key anchor of the healthcare system. So in 1977, under Pierre Trudeau, the feds essentially changed the terms of the deal and moved away from a 50-50 cost sharing to a health transfer scheme, and it's been called other things through the years, but essentially providing a block grant to the provinces to pay for healthcare services. And the terms of that deal, what the provinces had to agree to in order to get the federal money, the terms were really explicitly spelled out in the Canada Health Act in 1984. And many people, especially from outside Canada, will confuse the Canada Health Act with the Canadian health system as a whole, and think that it dictates totally how the system operates, and that it's the overarching architecture for the entire system. And that's probably not true, although it has pretty lofty rhetoric and includes important principles. All the legislation itself really does is explicitly set out the conditions that provinces must adhere to in order to receive federal funding for provincial healthcare delivery. Those decisions, of course, those strings, if you will, on the federal money, have had tremendous impact on which services the provinces have chosen to invest in. The 5 principles enshrined in the Canada Health Act were public administration, comprehensiveness, universality, portability, and accessibility. Folks in primary care in the community sector will often note that there was a missing reference, maybe a missing principle in the Canada Health Act with no reference to equity, which has led to some of the distortions you see in the Canadian healthcare system. There's also been a lot of discussion over the past several decades about how the exclusive focus on medically necessary hospital and physician services has really constricted the Canadian healthcare system from taking that next necessary step to what Tommy Douglas referred to as the second stage of Medicare, to focus on more upstream preventative and community-based services. The 2 other things just to note here, the health accords in 2004 and 2017, I think the thing that's important in these health accords to note is that they just signify a trend towards greater federal direction of funding. In 2004, the feds tied a lot of the money to explicitly to provincial action on wait times and primary care, and put a little bit of money in for e-health. And most recently in 2017, a good chunk of the money was directed to home and community care and to mental health. So if we have to kind of summarize the federal and provincial roles in healthcare, federal role is primarily a funding role in providing funding transfers to the province and setting conditions on that funding to ensure at least a baseline of a national standard for medically necessary physician and hospital service across the country. The feds also provide support service delivery to those populations I mentioned earlier, and have some other functions in product regulation like a drug approval, health research, promotion, and prevention, while the provinces have responsibility for management, organization, and oversight over the delivery of healthcare services. Although in virtually every province, services themselves are delivered primarily by private organizations, not necessarily for-profit organizations, but hospitals in Ontario are private, non-profit organizations. A lot of community support providers would be private, non-profit organizations. Family health teams, community health centers are not publicly owned institutions, they're private. The provincial role also includes oversight over municipal activity in healthcare. And it's important to note that municipalities don't really have any defined role in our constitution. They're essentially created by provincial government legislation, and they're given devolved authority by the provinces. So the provincial or the municipal role varies pretty significantly across Canada, and even sometimes within a province. Like the City of Toronto has its own standalone piece of legislation in Ontario, which gives it slightly different powers than other municipalities. But in general in Ontario, the municipalities have very key central roles in public health, ambulance service, and also the funding of a whole host of services, which would include, in some cases, supportive housing, community support services, municipal long-term care homes, and a whole host of other social and healthcare services. the dynamics between the federal government, the provincial governments, and the municipalities continues to evolve over time. This is not a static relationship. Talked about the fact that in the pre-1977 period, where there's cost sharing on hospital and physician services, where the feds there really was an expectation from the public and the federal government that they'd play almost an equal role in funding the system. After the changes made in 1977 to the funding formula, the federal share of healthcare spending, provincial healthcare spending, dropped all the way down to 14% in 1998-99. And the feds really drew back from their role in the healthcare system. And who pays the bills really matters. So the federal voice in healthcare arguably was pretty significantly diminished. They've been having more of a say over the last 20 years as they've reinvested through the health accord processes and targeted some of that funding, as we talked about earlier, to areas like wait times, primary care, and most recently, home and community support and mental health. One of the things that's surprising to many people outside of Canada and even many Canadians is just the really high level of private pay that's part of our broader healthcare system. And although physician coverage is 99% paid for by the public payer, a few things like maybe wart removal or mole removal or cosmetic procedures in physician offices might be paid for privately. Almost 99% of all physician costs are publicly paid. In hospitals, it's around 90%. But if you look at other professionals, and those would include a whole host of the types of professionals that would work in community health centers, nurse practitioner-led clinics, and family health teams, psychologists, mental health professionals, dietitians. It's almost the inverse. You've got almost 90% private pay in those areas, and also 90% pay in areas like dentistry, optometry, and things like that. Very, very significant portion of private pay in certain areas of the Canadian healthcare system, with half of that being out of pocket, paid directly by those individuals requiring service. Okay. The next slide just kind of puts that in further context by comparing Canada to our OECD peers. I don't think it requires any further commentary, just to show that in areas like drugs, that the private coverage is much more predominant in Canada than it is in OECD peers like Europe. Overall, Canada pays slightly more for its healthcare system than our OECD peers in Europe and Australia and New Zealand and peer jurisdictions. A lot of Canadians don't really know this because our headlines are dominated by facts about just how expensive the American healthcare system is. And I'm not suggesting that being so close to the US doesn't impact Canadian healthcare delivery. In some respects, we share a common labor market, and physicians in Canada, in part, are paid so well because physicians in the US are paid very, very well indeed, much higher than in Europe, and that impacts our healthcare spending level. But in general, Canada is slightly above that OECD average. If you break down what we spend this $240 billion a year on, 10% of our overall economy, a huge chunk of what Canadians do in terms of those working in the system, receiving care in the system. Between public and private, about 60% of all of the funding is broken down between hospitals, drugs, and physician costs, with all of the other service, dentistry, mental health services, home care services, long-term care services, all of that other services making up about 40%. So then the question is, well, how does our performance stack up? What does all this spending do for Canadians? How does it make us happier and healthier? Well, the answer is that Canadians are generally very happy with their healthcare systems. 3/4 of people say they're satisfied with the level of service they get, which gives us an A+ according to CIHI. It's 10% higher than the OECD average. But that kind of level of satisfaction obscures the fact that Canadians, by a lot of objective measures, don't really have great access to the healthcare system. There have been great strides made across Canada, and especially in Ontario, in people being able to get access to a family health practice. But 1 in 5 Canadians still report that they have to wait over a week to be able to get in to see their care team when sick. at the emergency department, a third of people are waiting over 4 hours to get in the door, and specialist wait times, it's over 50% waiting more than a month to access a specialist. So if you compare that to our international peers, Canada's performance in healthcare is really dragged down by the fact that timeliness of care. People simply can't get in to see their care professionals. The equity in Canada, because of that high degree of private pay, is also pretty shockingly bad and doesn't really jive with Canadian sense of self. We rank 9th out of 11 in equitable access to healthcare services. What's interesting, though, is notwithstanding those challenges, in terms of access to care, and particularly around coordination of care across the system, our health outcomes in Canada are pretty good compared to our international peers in areas like premature mortality and self-reported health status. And if you drill down at the provincial level, especially, you look at Ontario there. Ontario does incredibly well on self-reported health status, life expectancy, premature mortality. So really important measures of how healthy people are, and just as importantly, how healthy they feel they are and the quality of life they're experiencing. If you just compared Ontario here, Ontario and BC, which also does very well on health outcomes, to those international OECD peers, we'd be near the top of the pack on these health outcome measures, at least. So with that, I'm going to turn it over to questions if there are any, and if not, Janine will take us into the next section of the session.
Okay. I think there was one question. It was really thinking about Lynn's roles. I think when we had talked about the roles of the different levels of government, we talked about federal, provincial, and municipal. And indeed, Lynn's obviously have a very critical role, and that's a great segue actually into what I'm going to be talking about now. So thanks for that. And if there are further questions, we will have opportunity for discussion after my next section. So now I'm going to spend the next little while focusing in on Ontario and the healthcare system here. There are the interplay between the different parts of Ontario's system, particularly between the political side of decision-making, civil service that work in the ministries, the LHINs in particular, municipal government. It can be very confusing. We do have a complicated multi-level system. It's a big system. And we know it's sometimes hard to make sense of how decisions are made, the sort of theory versus the reality of how decisions are made, and as organizations and how sectors, how you can best be part of those decisions and play a constructive role within healthcare decision making and change. So we're hoping to make the system a little less opaque for you and to give you some practical information that you can use to navigate and really support you in all your various relationships in the healthcare system, and really getting back to what Adriana was saying, to be able to look at some of these disruptive changes really as opportunities to advance positive outcomes for your clients and the communities that you serve. So in Ontario, healthcare is by far the largest expenditure of the government. It accounts for 42% of government's program spending. So every year the government sets a budget and there's a finite amount of money to spend overall. So what that means is it's very challenging for any government to find new funding for healthcare. It's always a challenge. And at the same time, we all know that demand for healthcare is growing. So it's almost impossible to hold the line on healthcare spending without reducing access to services or angering some parts of the public in some way. And we can see that, we're at a time where there's a lot of public angst, at least through the media, around waits for services, overcrowding in hospitals, and some of that is a reflection of the fact that not everyone has the kind of access that we'd ideally like to see in the community and primary care. And some of it is about, some of the social determinants of health, like access to housing and so on. So it's not surprising that the three political parties have either promised or to increase or have implied that they'll at least maintain healthcare funding, and we'll obviously have to wait and see what the platforms say and what actually happens after the election. But given the size of healthcare and how rapidly demand is increasing with our aging population, there's always going to be a tension between spending on urgent health needs, meeting public expectations, but also maintaining investments in other areas that are critical to society, like education, social services, etc. And what typically happens when there is a push to increase healthcare spending is that other areas that contribute to health and well-being, the so-called social determinants of health, they're often the things that get squeezed to free up funding for healthcare. Things like social assistance and housing and education often see spending reductions or constraints. And you know as well as anyone that what ends up happening is that reductions in spending on the social determinants of health end up affecting people's health and end up causing pressures on the healthcare system downstream. The point of the next few slides is that is to really think through the key decision-making roles in Ontario healthcare system. There's obviously a whole complex ecosystem of players involved in the healthcare policy process, and it can be a challenge to keep up with who all the different players are and the dynamics, both in your local communities and LHINs, but also across the province. So this slide is meant to be a simplification because we really wanted to flag that it's important for you to understand who the key figures are. The two most important political players are the Premier and the Minister of Health and Long-Term Care. So the Premier is the elected leader of government. They're responsible for the government's overall agenda, and they, of course, have a major impact on the healthcare mandate in alignment with their overall policy agenda. Often the policy agenda for a government is originally set out in their election platform. Each minister today receives a mandate letter that spells out what they're accountable for. So so it is important for you to, if you're going to read any document, to familiarize yourself with what the minister is actually accountable for. It's pretty clear. In Ontario, and I might add that the LHIN CEOs have also received mandate letters. That's a new thing, so that's really important to know. In Ontario, the Premier has their own staff, that includes a special advisor on health policy, and that individual is an important person to know about. They provide strategic oversight on healthcare and direction to the minister's staff and others on the priorities of the Premier's office. The Minister of Health and Long-Term Care is the senior-most political official that oversees healthcare priorities. They lead the introduction of legislation and other policies. They're the key spokesperson for healthcare, and they defend the government's decision in the legislature in the media. They are, of course, supported by a large ministry that provides technical support and really is tasked with implementing policies. But the minister also has their own personal staff it can range between 15 and 25 people who provide the minister with policy advice, communication support, issues management, and they work together with MPPs regarding the rollout of government initiatives locally. The political staff can influence the minister's perspectives, and they're a key channel to reach the minister. The minister is also supported by a parliamentary assistant who's another MPP, and they're often assigned to lead an important portfolio. So John Fraser, for example, is now the parliamentary assistant for health, and one of his main tasks is to lead the end-of-life work for the government. There are also a cabinet committee or committees that have considerable impact on healthcare policy. So there is a health, education, social policy committee made up of MPPs from different, it's a cabinet committee, so it's made up of cabinet ministers, and it's important to know who's on that committee at any time. In terms of the non-political players, obviously the ministry and the local health integration networks are the two key players among others. We'll get into more of how the ministry operates in webinar 2, but we wanted to point out that one of the main distinctions between the political sides of government and the ministry is that the ministry is nonpartisan, and their job is really to implement the policies of the government of the day, no matter what their political stripe is. So the ministry does the analysis, they design options for policy implementation, they use the powers of government to execute policy and funding, but they also directly operate a number of government programs, namely OHIP, the drug program and others, and they oversee the performance of government agencies like the LHINs or provincial agencies like Cancer Care Ontario. Of course, there are many other ministers and ministries and levels of government that provide funding to primary care, for example, organizations. We do know, for example, that the community health centers receive municipal funding for some of their preventative and community programs, and so on. So we don't want to discount those other ministries. It's much more complex, but the key, obviously, the Ministry of Health and Long-Term Care and the LHINs are your key stakeholders. So as we all know, significant oversight for healthcare planning and funding has been devolved to the LHINs, and the LHINs were created in 2006, and their official role is to fund, plan, manage, and integrate a number of providers, which do include community support services, mental health and addictions, and community health centers. They do not directly fund, though, yet a large portion of primary care. So physicians' fees are still negotiated directly between the ministry and the Ontario Medical Association, and that's not likely to change anytime in the near future, but one never knows. And they don't directly fund family health teams or nurse practitioner-led clinics or Aboriginal health access centers, but it is the government's current intention that the LHINs will fund these other primary care models and will receive funding from the LHINs. But in any case, the LHINs do have accountability for planning primary care services overall and making sure that there's a good connectivity between the primary care models and the rest of the system. So more and more family health teams and others are, of course, working together with the LHINs and providers. Of course, CCACs were merged into the LHINs last year. So not only do LHINs fund and oversee home and community care, they actually directly deliver some of these services now, which is a pretty significant change. The next few slides really zero in on the LHIN model and how it works together with the ministry. So many of you are obviously quite familiar with the LHINs. You receive your funding directly from the LHINs, and you participate in a lot of LHIN initiatives and so on. But you may not be aware of how the model actually came into being and some of the really key features and how that really compares to what's going on in other provinces. So that's what we're going to talk about right now. Each province has a lot of leeway to structure healthcare delivery and oversight to meet their own regional needs and government preferences. And so each province really has pursued their own model of regionalized healthcare, largely through the creation of regional health authorities, but they've also transferred authority for health and social services, including public health, to municipal levels, which varies province by province. But the LHINs are a unique model. They were designed to be a Made Ontario model, and in fact, Ontario was the last province to regionalize. And the main reason why Ontario decided to regionalize is that Ontario's healthcare system is very large, geographically very diverse, and it really was felt to be unwieldy to try and manage the entire healthcare system from the ministry centrally at Queen's Park. One of the examples that was used at the time LHINs were introduced was when you look at the needs of a place like Toronto, densely populated, has a high concentration of academic health sciences center versus large remote areas in the north, and then the many rural communities that dot Ontario. Their needs are very different and the makeup of the healthcare system is different. And it was thought that we needed to empower providers and stakeholders in local areas to give them a greater voice in terms of articulating the needs of those communities, but also accountability for coordinating services for their populations on the ground. And the LHINs were the mechanism to do that. It's important to know that LHINs are responsible really for about half of healthcare services directly. The rest is largely overseen and managed directly by the province. So the ministry is responsible for managing large pieces such as the public drug plan, OHIP, family health teams, provincial programs like cancer care and cardiac, and they fund public health directly. The funding is split between the province and the municipalities. It's also important to know that funding for long-term care goes through the LHINs, and LHINs have an important mandate with long-term care, but also the ministry has a large role in regulating long-term care homes. So with so many different funders, it is challenging. We haven't mentioned all the funders, such as United Way and others, but it is challenging, obviously, for community-based providers in primary care. And it can contribute to some fragmentation. We thought it was important to flag that the current way that primary care is funded is one of the challenges with it is because there's different funding models for different types of primary care, this can lead to some differences in models, differences in standards, and difference in funding levels that may or may not be appropriate to delivering care in the populations, but it certainly is a challenge. And it has implications in terms of how you position yourself in the system and the relationship with the ministry and the LHINs. So just getting into the role of the LHINs a little bit more, the government set out really 3 primary goals when they created the LHINs. The first was they wanted to devolve decision-making more to the local level because they thought that together providers and the LHINs would be able to come up with more tailored and relevant solutions to reduce gaps and inequities in access. And how I'm going to give a few examples for LHINs with large growing immigrant populations like Central LHIN, for example. They're focused on strategies to increase access to culturally responsive services locally. For the Northwest, their focus is on virtual care and other kinds of strategies to connect remote communities to specialist services. And they're interested in building up community-based services to reduce the travel burden, so making more services available close to home through different kinds of delivery models. The second goal in creating the LHINs was better coordination. So the LHINs would provide a platform for organizations to work together, not only within sectors, but across sectors to coordinate services to meet the needs, not only of their clients, the people that walk in the door, but the entire population in the geography in which they're located. And the LHINs obviously have a mandate to integrate services in collaboration with health service providers, and really integration is seen as a way to ultimately create a more coordinated healthcare experience, a less fragmentation in the system for people. The third goal was to enable better management of healthcare resources. So as oversight bodies, the LHINs are accountable to the residents in their area, but the LHIN boards are also they're appointed by cabinet, and they're accountable to the Minister of Health and through the minister to the public at large. So it was thought that the LHINs, given their public accountability and their mandate to create one single healthcare plan for their areas, and the use of levers like accountability agreements and managing performance of providers, it was thought that the LHINs, together with providers, would be able to use these levers to improve the way that resources are allocated to meet the needs of local residents. I want to emphasize one unique aspect of the LHIN model that's really different, sets it apart from any other province, and that is that in Ontario, providers maintain independent boards. So in other provinces that have regionalized, they actually dissolve provider boards, and providers have become part of regional health authorities under a single board. There are, of course, a variety of views about the strength of Ontario's model. You'll often hear on the positive side that maintaining boards of provider organizations means that we have strong community involvement in healthcare and more fundraising ability in provider organizations. But you'll also hear criticisms that our system may be overly complex, and that with so many individual boards, this lends itself to more competition rather than collaboration. So I want to just look specifically at what the LHINs are responsible for. Collectively, the LHINs manage some 2,000 health service provider funding agreements and allocate over $25 billion, or just over 50% of the healthcare system. So they have a huge responsibility in the healthcare system. But it's important to note that when LHINs were originally planned, the expectation was that they'd be responsible for about 2/3 of expenditures. So they haven't quite got to that step yet, but they still, I think, with each year, the LHINs take on more accountability for healthcare funding. So the point of this next slide, 29, is to reinforce that while all 14 LHINs, they have a consistent role and mandate, same legislation, there is significant variability in the number and distribution of agencies in the LHIN, and that is in part a feature of the fact that each LHIN is a different size. They have different population size. It's in other ways historical. But it's not surprising that a lot of the LHIN's energy and time is spent on trying to create common goals for all providers in the system, enabling collaboration, and really focusing on getting better care coordination. Their central challenge is to try and get all parts of the system connected and moving in one direction. So how did the LHIN model evolve? Well, it's important to put this in the context of all of the other regionalized systems. The LHINs are only in their 12th year, so while it seems like they are an embedded feature of our healthcare system, and it's hard to sometimes remember a time when there wasn't a regional system in Ontario, they're pretty young when it comes to regionalized healthcare. And by design, the LHINs were supposed to have variability in terms of local priorities and strategies that they use to be responsive to local needs. But this is always a tricky balance, being responsive to local needs and context while ensuring that there's not too much variability and equity in terms of the services delivered and the outcomes from one part of the province to the other. This next slide, we're really talking about this challenge, this tension between being responsive to local needs and having kind of consistency and common standards across a province is really something that every single province is dealing with in some way. And so it's no wonder that some of the provinces have gone between more of a centralized model and a decentralized model over time. Alberta, for example, had a very strong regionalized system over a decade ago. They had a number of regional health authorities that were quite prominent, but they went almost overnight to having a single provincial health authority. And now they have planning regions, but really the single authority is responsible for planning and delivering all the full continuum of healthcare services. BC has regional health authorities responsible for more local or regional level services, but they also have a provincial services authority that's responsible for the province-wide services, very specialized services such as cancer care. Another feature that makes Ontario's model unique is that with the exception of home and community care services that were previously part of the CCAC, the LHINs don't deliver healthcare services. Other regional health authorities do deliver healthcare services. LHINs aren't mainly a delivery entity. And of course, there are debates about whether the LHINs have enough authority, have too much authority, or whether they've been yet given the ability to fully exercise the mandate to have the intended impact on the health system. But all signals suggest that Ontario will continue to devolve healthcare to the local level. Patients First, which is of course the current government's health reform strategy, created the subregions, and many of you will are part of subregions and probably participate in the creation of these subregions. But really, what they are is networks of providers across the whole continuum that operate on an even smaller geographic area than the LHINs. So there's roughly about 5, give or take, of these subregions in each of the LHINs, and they're responsible for really on-the-ground coordination of care and achieving one set of common goals for the population that they serve in their geographic area. It's really early days for these subregions. They build on a lot of the work that would happen with health links around highly complex populations. But it's also important to point out that many providers are already working collaboratively across sectors, locally, at the neighborhood level, at the subregion level. And in many ways, the subregions really formalize and actually leverage what is working well on the ground already. Both the Liberal Party and the PCs have supported the idea of devolving healthcare to locally, and so we've got the networks with the Liberals, and the PCs in the past have talked about hospital-led hubs as a potential model. We of course don't know what will be in their platform or what any government will do in the future, but we can say that the trend looks like it's continuing toward localization. This next slide is really a quote from the Auditor General's report that looked at the LHINs, and I think we included it because it's a pretty balanced view that does represent what a lot of stakeholders are feeling about regionalization in Ontario at this point, which is that There has been definitely progress in terms of provider organizations across the continuum of care working together more than they were in the past to find solutions for common healthcare issues. There's evidence of better coordination and alignment around common system goals, and all those are very necessary and positive things. On the other hand, there is some questions about whether the LHINs have yet evolved to a point where they can lead the achievement of a fully integrated healthcare experience for citizens. So the reality is that the way in which the power dynamics work and how decisions are made in healthcare is very different in reality than it is in theory. We kind of all know that, but it's very true, for better or for worse. And we know that the ministry has considerable oversight of the region, the health regions, at this point. And given how much the public values healthcare, there's always going to be political interest and involvement in decisions. And the LHINs have to be very aware of the political factors influencing healthcare in a way that perhaps the regional health authorities do not. So what this means is that any perceived changes that impact people's jobs or power structures, they can lead to conflict. And there's sometimes public blowback. And when that happens, that's cases where you will see MPPs or even the minister getting involved in decision making in areas that are really the domain of the LHINs and health service providers. And you will see that happening. And that's why it's, very important to kind of know the dynamics around an issue to figure out who's going to be involved at any one time. But one thing we all know for sure is that regionalization is going to continue to change. The last two slides are really some real-life examples that really show how decision-making can play out in practice. Everyone will have many different examples, but this one was a high-profile one. It is two hospitals, but I think a lot of people are aware of the merger between the Scarborough Hospital and Rouge Valley Hospital. And so back in 2013, there was an attempt to merge the two hospital corporations into a single hospital system for Scarborough. And there's a lot of reasons why that was promoted, but it got as far as the two hospital boards actually passing a motion in support of the merger. But despite the best attempts, I think, of both organizations, with the Central East LHIN playing a very active role, the merger discussions ended up falling apart. And that was largely because there was significant resistance, concern on parts of the public, and resistance from some physician groups at the time. And there was a lot of political involvement, not surprisingly, from local MPPs and city councillors. So in 2015, Minister Hoskin stepped in, created an expert panel, and recommended a plan for the Scarborough and West Durham hospital systems. And this led to the government recommending a merger between Scarborough and Rouge Valley for Scarborough, and then for parts of Rouge Valley to actually merge into Lakeridge in Durham. So that is a case where the LHIN ended up being a partner in an area where it would normally be the lead player in managing an integration. In that case, because of the political dynamics, because of the public sensitivity, the ministry played a key decision-making role. The next slide is really more relevant to the community and primary care sectors. And the point of the slide is really that local healthcare services are of great public and political interest. It's probably no surprise to you whatsoever. But the LHINs, as decision-making bodies, need to be very cautious about how they approach system change. And there's some thinking that some of the LHINs might move faster on structural changes in the community care sector or in the broader healthcare sector if there was less political oversight. So we all know local politicians are concerned about the optics if a provider is leaving their area, even if just the head office is leaving. And they want to be assured that any mergers or forms of integration or any service changes really don't cause disruption for clients and don't impact employees too much. That is why it's important to engage MPPs and municipal politicians in decision-making early and often. And these are just some headlines, but what they really show you, well, is there's a great deal of interest in novel kinds of models. There's one about Trenton Health Hub, and there's a lot of coverage of these novel models that really bring together not only health services, but social services, community-based services, and the CHCs have really played a leadership role in those models. And also there's one where even a case where a health professional leaves an organization can create a headline in small communities. So while decision-making is increasingly based on analysis and evidence, human and political factors will often trump good evidence when there's a conflict. So with that, we're going to see if there's questions, and we do have a question. Okay, great question. Where does public health fit in? Do you want, I think Dan's going to take this one. Okay.
Well, I think that question might have come up when we showed the chart of the ministry, where there's no explicit kind of line related to public health. And we just wanted to make clear that that chart is not the entirety of the Ministry of Health in Ontario. What we tried to do is summarize some of the key departments and branches within the ministry that were directly relevant to the audiences that we were preparing this webinar for. I think in webinar 2, there is a, which is happening next week, there is a chart that provides the full organizational structure of the Ministry of Health in Ontario. It's quite a behemoth, with thousands of people working for the ministry, and something like 25 different assistant deputy minister portfolios across the ministry. So a lot of things like e-health and other areas were not explicitly identified on that chart where you're trying to summarize things. Of course, public health is one of those areas where there's kind of joint accountability between the provincial government as a partial funder of local public health units and responsible for the overall kind of public health initiative at the provincial level, and municipalities who have a key role in those local public health units. There's long been a discussion about what the future holds for public health, and there was a panel report that looked at this recently, and there's been a lot of discussion within government about, when does the provincial government upload public health more fully, and how does public health get more integrated into the planning processes at the LHIN level. And the current government has really shied away from tackling that, particularly in the pre-election period, and has kind of punted that to the post-election, just because the issue is so rife with political complications in negotiating with municipalities, how that kind of transfer would take shape. So I think that's an evolving issue of how kind of primary care fits into this overall umbrella. You are seeing, though, the LHINs, notwithstanding the fact that public health isn't directly under the LHIN purview. Janine and I are doing some work for the Toronto Central LHIN on their strategic plan, and you're seeing the LHINs working much more closely with public health and with the city to deal with prevention and the integration of preventative activities with downstream healthcare services. Any other questions?
Okay, I think that's it for the questions for this one. We're going to go on to the last section, and we will have another opportunity for questions, and then also, just to remind you, an opportunity for you to weigh in on the questions that we pre-circulated.
Okay, so I'm going to be wrapping things up with a discussion of the operating reality that your organizations have been facing for the past decade, and really focusing on the funding environment and its impact. And you might wonder why we're spending a lot of time talking about funding in this webinar. And really the level of funding and how it's allocated directly impacts your organizational activity, your operating reality, how many clients you can serve, how many patients you can take on, the new programs you can offer, how much you can invest in infrastructure and administration to be able to manage all of the additional service demand that you're facing. In primary care, a big issue related to funding has been, how much organizations have been allowed to pay their staff, and the implications of that central funding freeze for frontline staff for about a decade on recruitment and retention that is now starting to be addressed. The reality that you've been living through is that primary care, like other areas of the healthcare system, has been caught up in an almost 10-year-long kind of austerity, period of healthcare austerity that was triggered by the 2008 recession. And after the recession in 2008, when government revenues really dropped off a cliff, and demand for care continued and actually increased in areas like social assistance, mental health, and access for or demand for healthcare services, the province found itself in a $25 billion deficit position. And really, when they looked at when the government looked at options for getting back to a balanced budget position, the only way that they could achieve it, given what was seen as the fragility of the economy, was to significantly rein in spending growth on public services. And a number of areas of government investment, and Janine talked earlier about the tension between investing in social services and healthcare. A number of areas of social expenditure in particular saw outright cuts to ministry budgets. Healthcare within that context was a little bit luckier. There weren't any year-over-year cuts in health budgets, but what there was a significant effort by the government to constrain healthcare expenditure in the neighborhood of 1 to 2% overall growth per year. And you might think, well, 1 to 2% a year, that's not that bad. At least it was going up. But you've got to put that within the context of the fact that demand for healthcare services has been escalating so significantly over the past decade. In addition to just the general run-of-the-mill inflation that you face in areas like your hydro bills, your leasehold costs, and staff wage demands, you also have to think about population growth, which particularly in the GTA in certain areas, and the Central Inn, for example, has been incredibly significant. At the provincial level, you're looking at about 1% population growth a year. You've got aging of the population. You've got increased incidence of NCDs and chronic diseases like diabetes that really require a much higher intensity of care. You've got the opiate crisis, and you really have you also have new technologies, new innovations, new treatment mechanisms coming into the system, which in some cases offer breakthroughs in care, but almost inevitably are much more expensive than the interventions that they replaced. So this has been a challenging dynamic for the government and for frontline health service providers to navigate. And I think from the government perspective, there was a belief that in order to navigate this kind of period of healthcare austerity without seeing massive reductions in public access to healthcare services, they really had to change how the healthcare system was funded, organized, and delivered, and really prioritize where those very limited incremental investments in the health budget year over year could be directed. Next, this slide shows that a core component of that strategy over the past decade, which is actually has been around longer than the past decade. This slide is almost 20 years compared 2000 to 2017. There's been an ongoing strategy in Ontario and in many other provinces to try and shift the proportion of healthcare provided in hospitals and the proportion of spending in healthcare from the hospital sector to the community sector. It's a recognition that the community sector is where a lot of people would receive evidence-based care, where a lot of people would like to receive care. It's often safer than receiving care in hospitals. But from the government perspective, it's also importantly quite a bit cheaper than providing care in acute care institutions. And although this doesn't seem like a massive shift, the fact that the healthcare spending in Ontario has gone from 41.5% to 35, just over 35.5%, a change of over 5% in the 17-year period, is very significant. It's been incrementally happening every year. And by this measure, Ontario is kind of further ahead of many other provinces, most of which still have hospital expenditure at around 40% of their overall budget. Now, the next slide shows that it was a concerted strategy by the government to focus that limited amount of incremental additional investment that they had each year disproportionately on community-based programs, especially on home care, community support, also some support for community mental health, and some targeted investments in primary care. the level of overall investment was almost double that in community programs to the hospital. But I think it's really, really important to know, and I was talking to Adriana about this before the session, that a lot of the frontline providers didn't actually feel that they were receiving any additional services. And that's because for most of you, you would have had your base budgets frozen since around 2009 until 2016-17, a complete freeze on compensation for non-physician healthcare providers, and an increasing demand for you to be able to provide more services with the same administrative footprint. You know, overall, if we look at the healthcare funding dynamic that you've been facing, it's that you've been asked to really live within a pretty static budget, even as the demands on you related to population growth, aging, and incidence of disease have continued to grow. Where new funding has been made available, it's usually been tied to new services and new models of care. I mean, Adriana referenced just recently when I was talking to her that the funding was targeted towards addressing the opioid crisis and refugee health clinics. But this funding has often been provided with the proviso that it all goes directly to service delivery and to kind of frontline care, if you will, with no net new investment in administration. So this has placed a lot of pressure on service providers to operate in a super lean manner with administrative structures that really haven't grown to meet the new size of the operations that have often grown significantly in response to emerging patient demands. So to kind of summarize what this dynamic has meant for you is, little or no base increases. There was $128 million put aside in the 2016-17 and 17-18 budgets to address primary care non-physician compensation. So that will start to address some of the compensation challenges that many of you were facing, although many would argue it doesn't go far enough. It will start to it is hoped by the government anyway, to address some of that massive retention challenge that family health teams, nurse practitioner clinics, and CHCs were facing. You are still facing this dynamic, though, that there isn't really money available to address any of these other inflationary pressures that you've been facing related to hydro costs or leasehold costs or those kinds of things. So it creates a very difficult operating environment where the funding that's available to you is almost entirely been tied to new service delivery expectations and very little set aside for your ongoing operations. That challenging kind of dynamic aside, it's really been impressive the leadership role that organizations in the community sector have taken in really being able to try and do more with less, and as Adriana put it, to become a critical anchor of the healthcare system, and to invest in not just providing more service, but providing service in new, innovative ways, often through partnerships. And primary care has really emerged as a kind of foundation of the system in advancing new models of service delivery, looking at care coordination, for example, and advocating for firmly embedding care coordination as a core function of primary care, taking many steps to work across sectors in areas like mental health to bring primary care. In a way, primary care was often has often been talked about in the healthcare system as a silo within the siloed healthcare system. The primary care kind of stood alone and wasn't interconnected with the rest of the healthcare system. We're seeing all kinds of initiatives across the province where family health teams, nurse practitioner-led clinics, AHACs, and others are taking leadership from the grassroots level to connect more effectively with others in the healthcare system and to lead change. Although primary care got targeted funding in the 2016 and 17 budgets, it was a bit of an outlier in that respect, really. Your associations have been advocating for 5 years, I think maybe even longer than 5 years, with really a wall of resistance within the Ministry of Health, given their lack of funding to be able to address compensation. That changed in 2016-17. Many others in the healthcare sector, like those in community mental health, home care, and others, really had to wait until 2018 to get any sign that this austerity, this long-term kind of austerity agenda in healthcare was thawing. And the budget committed almost 5% annual growth between 2017, 18, and 2021. So pretty significant departure. It must be noted that even with that level of funding committed, organizations, you folks in primary care, there's still going to be a delta or a gap between the growth in demand for your services and the government funding available to address it. Demand growth driven by those kind of key factors of demographic change, population growth, new technologies and procedures, really continue to place pressure on health service providers to find new innovative models of meeting that demand within a budget that doesn't keep pace. The question on this 2018 budget, sorry, just to go back to the previous slide, is whether this budget marks a true inflection point, or whether government changes in the upcoming election and a new government continues with a path that seeks to constrain healthcare expenditure to free up money for other priorities, be they tax cuts or balancing the provincial budget. This is a budget that was tabled pre-election by the Liberal government, and the specifics of it would only be implemented if this government was returned. Although the NDP in its recent platform essentially committed to a very similar investment profile if they were to be elected. We've yet to see really any details of the plan from the Progressive Conservatives about what they would invest in the healthcare system and what their priorities would be. Next slide really is just to summarize. We think it's fantastic that you've got I think something like 65 emerging leaders and emerging and established leaders from the primary care field on this call who are obviously interested in understanding what they can do to drive change from the ground up. And it's worth noting that you're having tremendous success in doing that, and that the system is responding to the advocacy that's being brought to bear by the broader community sector. And you are seeing the work that primary care has done on community hubs, the work that the primary care sector has done advocating for compensation changes, the work that your associations have really been doing advocating for integrated service delivery models, really is changing how the services are organized and funded at the provincial level. The final thing that we wanted to leave you with, the final slide, is these quotes kind of come from the Change Foundation work, a lot of the work that they've been doing. And it's just to reiterate that our healthcare system generally, notwithstanding some of those access challenges, generally it's acknowledged provides really good care once you get into the system, once you're within one of the silos of the system. Where it really falls down in terms of management of complex chronic disease and these hard to serve populations that really require integrated care across the system is when people transition between care. And that's why it's really important that primary care continues to play a leading role in addressing these care coordination and case management and patient navigation challenges that are rife across our system. Thanks for that, and we're going to turn it over to questions before we wrap up.
So before we get into your questions, we want to give people an opportunity to weigh in on the question that we put out there. And the question that we sent in the pre-circulated materials were, the majority of primary care is not under the LHIN purview, but how are you engaging and communicating with the LHINs? So if anyone has thoughts on that or experiences, how they're engaging with the LHINs, we'd love to hear your ideas. In the meantime, there's a question that came in. And the question is for us to comment on why and how the multiple physician payment models are actually evolving. So the fee-for-service model, blended capitation and FHT, salary and CHCs, how are they evolving? Why are they evolving? I'm going to ask Dan to start answering, and I can jump in after.
Okay, great. This kind of puts me back. going back in my mind to when I sat at the OMA negotiating table, back when the government and the OMA actually successfully negotiated physician services agreements. And one of the reasons why you have this diversity of physician payment models across the province is a recognition that physicians are different intrinsic motivations and different practice approaches. So if you look at the CHC compensation model, salaried model where physicians are employed by their providers, Adriana might have a different perspective on this, but from what I saw, at the dealing with the physician population in general, is that kind of model of payment appeals to a very distinct kind of subset of the physician population who have different motivations, different expectations of how to practice than many, many other physicians. So while that salaried model might work really, really well for CHC physicians, many other physicians, it would be totally anathema to them, and there would be a real challenge if you try to impose that kind of system. There are other doctors who really, really like the kind of fee-for-service model, and particularly the older physicians who grew up, very comfortable with that kind of approach. Physicians saw this kind of capitated plan as back in the late 90s and early 2000s as almost like a scheme by the government to control them, to get them on a quasi-salaried model where the government could tell physicians what to do more. And there's still a significant chunk of physicians, particularly older ones, not to stereotype them, but just because they're more comfortable with that kind of model of practice, where there's intrinsically a bit more freedom for them in being in a fee-for-service model where they get paid for each interaction with the patient. The government really around 2000 started pushing more for a capitated approach in primary care, just because they saw the huge challenges with a blanket fee-for-service model that led to, in some cases, to significant over-servicing of patients and not really a focus on quality or outcomes. So, if you only got paid for seeing patients, why not bring them back in every couple of days instead of dealing with their underlying issues? So the capitated model was a response to that, and it was advocated for by a kind of cadre of physicians who said fee-for-service for them was incompatible with providing good quality care. And the funding models, the kind of faux funding model that family health teams would be familiar with, there was a recognition within government that there had to be a kind of financial incentive to get a lot of those physicians over the hump, to make it an incentive to switch from the fee-for-service models they were comfortable with. So if you look at the data now, physicians practicing in faux models, I think are making a significant percentage more than those that are practicing in fee-for-service FIG models in general. And what happened there is that there was almost an unexpected, you'd think that the government would have expected it, but there was a stampede, particularly amongst younger doctors, to try and get into these capitated models that not only were more in sync with how they wanted to practice and less being on the clock and billing for every patient, but were also much, much better compensated. I think the figure I saw a few years ago was physicians in FOs were receiving something in the neighborhood of $450,000, that you then have to deduct expenses from, compared to something in a lot of the family health groups with CHCs further behind that. So there's a huge incentive for physicians to want to move into those models, and the government got a little bit panicked that maybe they weren't getting full value for money out of these new capitation models. So that's where you've seen the government, the Ministry of Health, really start gating how many people get into the faux models, while they said that they wanted to do a pause and reassess the impact and the outcomes associated with those investments. Were they getting good value for money? Were docs working in faux models really reducing emergency department visits and downstream costs more than docs in family health groups and fee-for-service models?
Hey, thanks, Dan. We have received a couple of comments from people on their own experiences regarding working with the LHINs, and so I'm going to just go through some of them. And I think those on the line can probably see some of these, but I'm going to read them out anyway. So we have Sherry Kennedy of Tattle Creek Family Health Team is saying that they're engaged with the LHIN in many ways. Here are two examples. The lead physician at Tattle Creek is part of the Primary and Community Care Committee. That would be with the Toronto Central LHIN. And as the executive director, Sherry is on on many of their models, approaches, and organization of care task group. Thanks for that. Lori Oswald has shared that we've been organizing locally in a collaborative model within our subregion, at which the LHIN is an active member at our table. Jocelyn Maxwell says that in their subregion, all primary care models are at the planning table with the LHIN, thus have opportunities to shape and influence planning and service delivery along with providers of other sectors. That's great. And there is Lisa, as said here, talking about we have entered into a collaboration agreement with our LHIN and CFHI to address suicide prevention and life promotion. And there's a few that have come into us just directly that I will go through. One other individual said that both the family health teams in Burlington are active participants in the development of the Burlington subregion and sit on the anchor table. And another one saying that there are 4 family health team executive directors at that meet monthly, and the VP of primary care for the LHIN is a regular guest and provides updates and discussions on the LHIN provincial strategy. So I think what this tells us is there's a lot of involvement. You know, obviously the community health centers have been part of the LHIN universe for a long time, but the family health teams are quite involved in leadership and implementation tables with their colleagues across the system. So thank you for sharing those examples. I think we're looking at the clock and we're just a few minutes to end our webinar. But before we wrap up, I just wanted to say a few words and then ask OCSA to provide some final useful information. So we just really wanted to thank everyone who joined us today. There was a really good turnout of leaders, and I know how busy your schedules are. So we're really thankful that you gave us the time, that you stuck through the hour and a half, and the dialogue has been terrific. And so again, thank you so very much. And we hope that you do join us on April the 26th to continue the conversation and to get a little deeper into some of the really important issues that we started to just scratch the surface on today. So now I'm going to ask Kathleen of OCSA to end the webinar with a few important details. Thanks.
Thank you, Janine. I'm just jumping on Adriana's headset here. Just wanted to thank again Janine and Dan for such a comprehensive overview today of the Ontario healthcare system. Just a little behind the scenes information. We've been doing a marathon of 3 back-to-back today, so a mental round of applause to everybody here. I just wanted to let you know that the evaluation will pop up immediately after the webinar, and you'll also be emailed a link following as well, so 2 options to complete that there. Your feedback is so important to us because this will inform how we select themes moving forward. So I've also entered in the handle for Twitter there that will give you a great avenue to get the most up-to-the-date information about our upcoming leadership webinars and also any other components, including our Leads Learning series that we're featuring across the province. So again, Nicola is going to be sending out an email after the webinar today, including the slide deck, the recording, and the link to register for webinar 2, which is a week from today. So please join us next time as we continue on in terms of digging deeper into what these policies mean to you specifically in your daily roles. And finally, next week, stay tuned as we prepare to launch our project-specific website. And that's a leadership project-specific website, and more information coming to you about that via email and Twitter as well. Again, as Janine said, we appreciate your very precious time, and please don't forget to come back and join us next week. Take care, everybody. Bye-bye.